The following is a production of Spark Study Club. To see the full video presentation and receive 1 CE credit, please visit sparkstudyclub.com and register for your free account today.
Hello, I'm Adrienne Good with Spark Study Club. Welcome to this presentation and Q&A titled From Panic to Protocol, Mastering Medical Emergencies in the Dental Office with Dr. Mark Donaldson. Before we begin, I have an important announcement about how we receive your 1 PACE CE credit for this webinar. About 1 hour after we've wrapped up here, you'll receive an email to access this course module on our site, which includes the recording along and a survey. So please complete the survey to receive your CE certificate. And if you have any questions, you can reach out to us by email at support@sparkstudyclub.com or by clicking Contact Us on our website. So next, I wanted to give a special thank you to our sponsor for this webinar, which is VitAlert Kit. It's a leading provider of medical emergency kits for dentists, oral surgeons, and anesthesiologists. Their mission is to supply your office with a medical emergency kit that is customized for your dental practice needs and to help you keep your kit updated so you're always ready for an emergency situation. And lastly, I want to remind everyone to use the Q&A feature in the control panel to ask any questions. They'll be answered at the end of the session as time permits. Now I'm pleased to introduce our speaker, Dr. Mark Donaldson. He's currently an associate principal of clinical pharmacy at Vizient Advisory Solutions and lives in Whitefish, Montana. Dr. Donaldson is a clinical professor at the University of Montana, clinical associate professor at the Oregon Health and Sciences University, and affiliate faculty in dentistry at UBC. Dr. Donaldson serves on the editorial board for the Journal of American Dental Association and is the 2016 recipient of Academy General Dentistry's Dr. Thaddeus Wakelu Award. He's lectured internationally to both dental and medical practitioners, focusing on dental pharmacology and therapeutics, and is a leader in the field. Thank you so much for joining us, Dr. Donaldson. Now I'll turn it over to you to learn more about mastering medical emergencies in the dental office.
Thanks, Adrienne. That's a super introduction. Did a great job there. And wow, that's a lot of information, probably more than people wanted to know about me. But with that very kind introduction, let's get started.
Absolutely.
Now, the most important thing on this slide is my email address. I try to return all of my emails within 24 hours unless I'm traveling. So please make note of that. And hopefully this will be the continuation or start of a long-term relationship. With that, let's jump into it. Now, I would be remiss, of course, if I did not mention that I have received an honorarium to prepare this presentation. I have no financial interests that would create a conflict of interest or restrict my independent judgment regarding the content of this course. So with that disclosure out of the way, I will also just make mention of the fact that the little placard in the top corner with a number references where we are in the handout. So there is in fact a handout that goes along with this presentation. And the good news for you is that every single word on each of my slides is in the handout. So if you are following along, or if you're just wondering where the content is in the handout, that little placard and number will tell you exactly which page. With that, I want you to sit back, relax, and enjoy this conversation. So, why are you listening to this today? What are the fundamentals, if you will, of emergency preparation? In other words, what is the why? Why is this important? Well, they happen more often than you expect, especially when we consider medical emergencies in the dental office. And while many of you have probably been practicing for decades and have not experienced a medical emergency, that's great news. But when you do, in fact, look at the data, you can see that on average, you will experience a medical emergency at least once for every 2 years you practice. Now, when I first put that statistic up, and you can see that there are a number of references in support of it, there's always this thought that, well, what is a medical emergency? I don't feel like I'm seeing more than one medical emergency every couple of years, Mark. So what are you really talking about? Well, we'll see the list in a minute, but I think that if I was to ask everybody, does this resonate with you? Initially, you'd probably say no. I just don't see that many medical emergencies until I ask you if you've ever had a patient faint. So in that case, syncope or fainting is in fact a medical emergency. The good news is that we cannot move humanly fast enough to get a blood pressure cuff on the patient. Otherwise, we might join them on the floor. Asystole actually results in blood pressure dropping to 0/0. Now, not for any extended period of time. We're really just talking milliseconds. But if we were to get a blood pressure cuff on the patient during a faint, the most common number we see is maybe a pressure of 80/60. So that's pretty low, and maybe we took it wrong. So we'll try again, and maybe we see now it's 100/80. Still seems pretty low. But at least it's going in the right direction. So let's do one more, and by the time we sort of get that third blood pressure reading, we see it's back up to 120/80, and that's usually the point at which the patient's eyes sort of flutter open, and they say, hey doc, what's going on? And you say, well, you fainted. Now, because syncope does tend to be fairly common, especially in the dental office, we do not necessarily treat it as a medical emergency. But in fact, studies have shown that these patients do not recover hemodynamically for up to 48 hours. And most commonly, if it's fine with you, if it's fine with the patient, and they want to continue on with dentistry, that's typically how we approach this. But just know that fainting or syncope is in fact one of the most common medical emergencies, and in some cases it can in fact be life-threatening. All right, so why should you really care about medical emergencies? Well, our good friend Dr. Stan Malamed, who has probably done more research in this area than any other oral healthcare practitioner, and again, we're looking at not dental, but medical emergencies in the dental office. One of Dr. Malamed's most robust trial looked at almost 14,000 emergencies over a 10-year period, and he found that almost all medical emergencies in the dental office tended to be fear-related, which always brings to mind a couple salient points. There have been studies over and over again taking a look at the prevalence of dental fear in the general population. And studies continue to show that even today in 2026, that greater than 50%, that's 50% of the general population will self-report as being fearful about going to the dentist. And in fact, 15% of the general population will self-report as being terrified, highly fearful of going to the dental office. So you can just imagine bringing those people in, and if they have any type of concomitant disease, any type of underlying medical condition, angina, cardiac issues, that certainly puts them in a high risk category to experience a medical emergency in your chair. So if fear and apprehension are reduced, the chances of having a medical emergency are also reduced, which gets back to where we started when I gave you that initial statistic of experiencing a medical emergency about every 2 years that you practice. If you already do a great job of intraoperative local anesthesia, that may include a buffering of your local anesthetic. If you do a great job of getting your patients to relax, whether that's just the general TLC when they come into your operatory, or maybe that's the nice music or glasses that you put on the patient, or just your staff's overall approach to managing patients, you are already doing a great job and probably will not have as high an incidence of medical emergencies as we've seen reported in the literature. But if we do take a look at the list, and again, Dr. Malamed has provided us with sort of the top types of medical emergencies that we will most commonly see in the dental office. You can see that again, syncope, fainting, tends to lead. And then we have some allergic type reactions, ischemic heart disease, also known as angina, seizures, asthma, and the list goes on. Most importantly, again, we've emphasized it once, but let's put a number to it. 75% of all of these medical emergencies developed as a sequelae of pain, the dentist's failure to recognize and treat a patient's fear of dental care, or both. So by providing excellent intraoperative local anesthesia and providing an environment where the patient can relax, whether that's with some of the techniques that we described already, whether it's with an intervention such as inhalational sedation with nitrous oxide and oxygen, or maybe it's oral sedation, minimal or moderate sedation with one of our oral medications, anything like an antihistamine or even a benzodiazepine, a Valium-like drug. or perhaps for some of our most fearful patients, a combination of inhalational sedation with oral sedation. But the teaching point here really is we need to think about our patients, and we need to understand their pharmacological and medical history, and we need to be preventive in hoping to avoid medical emergencies in the dental office by intervening early and getting good data. So what exactly does that look like? Well, first of all, pilots, if you weren't familiar, pilots oftentimes talk about a critical window, where the airplane is really under their control, and that's usually the 11 minutes of taking off and landing. Outside of that critical 11 minutes, the plane is pretty much on autopilot, and they really don't have to touch the stick at all. So how does that relate to dentistry? Well, dentistry also does have sort of a critical time period. That critical time period, as you can see here, is round about the administration of local anesthetics. In fact, almost 55% of all medical emergencies tend to occur round about the delivery of local anesthesia. So once again, you want to have a high index of suspicion, especially in your patients with a significant medical history, that if you are going to experience a medical emergency, it almost always tends to be round about the time of local anesthesia administration. All right, so we've sort of defined that time of the appointment where we're going to have this high index of suspicion. We have taken a look at the list of the most common medical emergencies, and we've recognized that if we just provide good pain control as well as good sedation, we may never see any of these, which is fantastic. Now, I hate to say it, but in this day and age, 2026 and beyond, it's not just about the dentist. In fact, again, our good friend Dr. Stan Malamed here has recognized that dental hygienists can and will be held liable when a medical emergency occurs and the patient's condition is improperly recognized and inadequately managed. The dentist will also be held liable, of course, but all other members of the dental office staff, including hygienists, dental assistants, and possibly even front office personnel, can be included in the legal or dental board regulatory action that may follow an emergency incident. So what does all of this really mean? Well, it takes a village, it takes a team, and medical emergencies really do require attention by the entire staff to not only be able to recognize that an emergency is occurring, but what their role is in the office protocol. So we definitely want to have an office protocol. We definitely want everybody to know what their roles are. And of course, we want to practice because we want to make sure that we get this right first time, every time. And if I had to put a fine point on it, is it just because of this liability issue? Well, not exactly. I mean, we always want to do the right thing. And in fact, our most, probably I would say, acute initiative is to avoid medical emergencies if we can. But since they do happen to occur without warning, they are unpredictable. We want to be well trained so that if we need to jump into our PABCDs, position, airway, breathing, circulation, and D, definitive care, which could be the use of an automatic external defibrillator, that everybody knows exactly what their role is, who's calling 911, who's staying with the patient, who's getting the medical emergency kit, and how can we stabilize this patient. I love this quote from Nelson Mandela: "One cannot be prepared for something while secretly believing it will not happen." And so we've seen the statistics. It's going to happen at some point during your professional career. And while unpredictable, we can at least make it a little bit more predictable as far as the outcome if we practice and make sure that our team knows their role. So I do think that the Boy Scouts had it right. This is definitely something that we want to be prepared for. And I think with good preparation, with practice, and with continuing to update your staff on any new changes, and making sure that they understand their roles, that you'll be very successful in managing any patient situation. Now, if I had to put everything you need to know on one slide, the fundamentals of emergency preparedness really are this. It starts off with training, which is why all of us for licensure are required to keep our basic life support, or in some cases, intermediate life support. Or if you do practice at a higher level, your advanced cardiac life support, or if you treat kids, pediatric advanced life support, up to date. And so if you want to renew your license, in order to do so, we also have to make sure that our healthcare provider status is also being renewed. And so that's typically every 2 years through the American Heart Association accredited courses. We want to develop and implement an emergency plan. And so this is something you share with your staff, definitely new staff that are coming on, especially if it's sort of mid-cycle. Maybe every year you do review your emergency preparedness with your staff, but don't forget throughout the course of the year, you may have added new staff. And I always think too, it's not a bad idea to have some competency quizzes. So not just a pizza lunch to cover what everybody's role is and what we need to do in case there is a medical emergency, but actually make the staff a little bit more responsible for having a quiz to check their competency and understanding of their role, and make sure that you keep copies of that every year. Purchase and maintenance of emergency equipment and drugs. We'll talk a lot about the equipment for either monitoring or helping to understand a patient's status during a medical emergency. And definitely we will focus on the 7 drugs that make up the minimal dental emergency kit. And that, of course, is going to include the new 8th drug, which is naloxone, the reversal agent for opioid overdoses. Periodic mock emergency drills. And that's exactly what I was just referring to. In some cases, it can be as simple as, a pizza lunch with the staff once a quarter to go over different emergency drills and make sure everybody knows their role and what to do. Training new staff members, again, always worth saying some things twice, but they tend to be hired throughout the course of the year and may have just missed that last mock emergency drill you had. So, what does your onboarding look like for new staff as far as making sure that they are prepared and they know their role in the case of a medical emergency? And then finally, assessing patients' medical complexity and appropriate monitoring. So we'll jump into this as we go along because the best thing to do is to be well prepared. And how do we prepare ourselves? By getting a complete medical and pharmacological history on all of our patients prior to any dental appointment. Now, there is a very important mathematical equation that we need to also understand, and that is that our cognitive ability tends to be inversely proportional to the severity of the emergency. In other words, we do get a little dumber as things start to unravel quickly. And I have certain individuals that have told me, Mark, in the middle of a medical emergency, I completely forgot to call 911. Or, I picked up the phone because I knew I had to call somebody and I couldn't actually remember that it was 911. So I will tell you right now that that's always the right answer on the test, right? Call 911, get the experts there as quickly as possible. And then hopefully your office protocol includes those PABCDs that we talked about. You want to make sure that you keep the patient comfortable until those experts arrive. But if you needed to provide definitive care, so again, an automatic external defibrillator or D as in drugs, that you're well managed and ready to do so. So these are the rights. We talk about this a lot in medicine and pharmacy. Right drug, right dose, right patient, right procedure. As long as we do all the right things, then we tend to have successful appointments. But there are certain rights that I want to highlight. I won't go through every single one of these. Hopefully you are giving the right medication, the right dose for the right procedure. But that first and perhaps most important right is the right patient. Is the right patient in front of you? Is your office the right place to treat them? And do you have the ability to manage this patient if you get all the right information up front? So what am I really talking about? Well, again, the best preparation is prevention. So anytime a patient comes into your office, you want to update their medical pharmacological history, get as much good information as possible. So lots of different examples out there of different medical histories. But I think most importantly is not that you're just asking patients to fill out an intake form, but that you are in fact sitting down knee to knee, eye to eye with the patient to go through that report together. Definitely if they have any new medications, if they've had changes in their medication or doses, if they've had any new medical diagnoses or new medical visits. And then one last thing, which is not clearly shown on the examples that I'm showing here, but when you do sit down and go through the medical and pharmacological history with the patient, I think it's also important to have your signature and their signature on there that you did this, and of course a date. So you want to make sure that everything is time oriented, so that if anybody was to ever look at your files, you'd be able to clearly show that that this information was covered by both you and the patient, signed and dated it. Now, a quick word just about our patients, because historically, I may stand in front of a group and ask, how many people have diabetics in their patient population? And I will tell you that, 20 plus years ago, it wasn't everybody in the room that would raise their hands. And so when we do go back, let's just say 16 years ago, the Center for Disease Control was quoted as saying federal officials estimate that by the year 2050, as many as 1 in 3 U.S. adults could have diabetes. So that goes right along with my experience, 20 plus years ago, that, a handful of folks would say, yeah, I've got some diabetics in my patient population, but not necessarily everybody in the room. Now, it's not 2050 yet, but only 11 years later in 2021, you can see that the CDC redacted their statement and based on new information, announced that federal officials now estimate the year 2050 that 50%, that's 50% of all U.S. adults will have diabetes or pre-diabetes. So right up front, this becomes one of the most important areas to be aware of, that we are going to be treating more and more diabetics in our patient population. And for that reason, it may be worthwhile to have a greater understanding of how to manage these patients, and maybe even a way to sort of understand where they are in regards to their control of blood sugar. So one of the things that is not routinely requested by dental boards or dental colleges is that dental offices retain some type of diabetic monitor, something like a glucose monitor. These are very inexpensive, typically less than $20. And all you're doing is taking a drop of blood, putting it on the test strip, inserting the test strip into the machine, pressing a button, and within 30 seconds, it will tell you what that person's blood glucose level is. And so very, very easy to use, very inexpensive. This is not for you to diagnose diabetes. That's not the intent. But based on the statistics I already shared with you, that greater than 50% of the general population has some measure of fear or anxiety about going to the dentist. And then you couple that with the fact that up to 50% of the population is going to have diabetes. If you are providing some type of relaxation dentistry, and you have a patient that may appear confused, might be hungry, may seem drunk, might have some slurred speech, is that great sedation? Because that's what a lot of our sedation patients look like. Or could this be a hypoglycemic event in a patient with a history of diabetes? So they both look and feel exactly the same as far as their symptoms go. And in one case, great sedation, continue with the dentistry. In the other case, a medical emergency, and you need to react quickly. So how do you tell the difference? Well, the use of a glucometer would be very handy if you happen to have one. And you don't necessarily have to lance the patient's finger and squeeze out a drop of blood onto that test strip. You have access to blood in the sulcus. It's the same blood, so you could take a drop of blood from the sulcus, put it on the test strip, and like I said, within 30 seconds, know very quickly if you just have great sedation or if, in fact, this is a medical emergency, hypoglycemia, and you need to respond appropriately. Now, it doesn't matter to me which glucometer you invest in. I've put a range of different ones out there, but they all basically have the same technology, all very, very easy to use, and all similarly inexpensive. Last piece I just want to again highlight, should be obvious, but always worth mentioning, is that if you are going to be providing some form of sugar to a patient that has a hypoglycemic event, that we never put anything into the mouth of a patient that is unconscious. So the right answer, as I've already mentioned, is if a patient does go unconscious, you're already calling 911 and you're supporting the patient until the EMTs get there. But if the patient's just not feeling well and based on their blood sugar reading, it looks like they're hypoglycemic, then we'll take a look at what some of the options could be to sort of perk up their level of sugar again. Now, there are some other options out there. For those of you that have kids, maybe you've gone to give your kid one of those fever strips across their forehead that tells you their temperature if you're concerned that maybe they've got an inner ear infection or something. Similarly, there is a glucose strip. So this is a non-invasive test, a very similar strip that you put on the patient's forehead as an example, and using the concentration of sugar in sweat, it will, as a surrogate, record a blood sugar for you. So that's another way that you could go. Or for those of you that still remember Lance Armstrong and the yellow bracelets that he used to have, those Live Strong sort of rubberized bracelets, there is something called a gluco watch also. So a non-invasive band that you put around the patient's wrist, and again, as a surrogate, measuring the concentration of glucose in sweat and reporting that as a blood sugar measurement. Now, again, those two devices probably not diagnostic in any way, but just simply to monitor non-invasively where that patient's level of blood sugar could be. Those are a couple other options. So just letting you know about some of the tools that are out there. So one of the other rights then is the right monitoring equipment. And since we are talking about this large diabetic population, I've introduced the idea of at least having access to within your office something like a blood glucose monitor. If it does turn out that the patient, usually with a history of diabetes, and these are most commonly patients that are the last appointment before lunch or the last appointment of the day. Typically, they are in your high fear diabetic patients who were just so nervous about the dental office that they may have gone off their usual nutritional schedule. And so they don't have enough calories on board, and they start to get low blood sugar in the dental chair. So what does the American Diabetes Association suggest? That they eat or drink 15 grams of carbohydrates, wait 15 minutes, check blood sugar, and then you may have to repeat if their blood sugar concentration remains below 70 milligrams per deciliter. That 15 grams of carbohydrates could be 4 ounces of a non-diet carbonated beverage. So that could be a can of Coca-Cola or a can of Pepsi, just not diet Pepsi, or juice. 3 glucose tablets, 1 serving of glucose gel. Sometimes I find it's hard to memorize all of these, which is why I love this next little slide where it really kind of gives you a great option. For those of you that like candies and other sweets, there's an example of a lot of commonly used candies and sweets and how many you would have to give in order to provide 15 to 30 grams of a quickly absorbed carbohydrate. There are some of the beverages that we talked about, and again, it's a non-diet carbonated beverage. Typically, that is the drug of choice by the American Diabetes Association because the carbonation tends to open up both sphincters, allowing the liquid sugar to get very quickly down to the small intestine where it's absorbed. You can also give fruits. You can see that there, and then of course the glucose tablets or gel. All right, what else do we need to think about? Well, take training, practice, and then more practice. So we've already talked about some of the mock drills that you want to make sure that you have with you and your team so that everybody knows their role in a medical emergency. And that kind of brings up this idea that, do you have the right team? Is this the right environment? How often are you doing those mock drills with your team, and are they successful every time in knowing their role, knowing where the emergency kit may be, and knowing who calls 911, who goes outside to flag down the fire department or the EMTs as they get close to your office. All of those pieces need to be well understood by the staff. And as I get back to some of those whys, Dr. Larry Sangrick here in a publication by the American Dental Association, you can see this, and the citations also given in your handout, but every member of the dental team should be involved in the care of any patient who experiences a medical emergency in the office. In other words, it's not just up to the doctor. The doctor is going to need help. In the case of a true type 1 IgE-mediated anaphylactoid reaction where you need to get life-saving epinephrine into that patient as quickly as possible, that's the choice the doctor is making. Does he or she call 911 or do they administer life-saving epinephrine? And of course, they administer life-saving epinephrine, which means somebody else has to be calling 911. So everybody has to know their roles. Very, very important. And the right team, sometimes the right environment, the right support, are highlighted by some of the pieces here. In other words, when we talk about the right environment, do you have the appropriate equipment? Now, in some of those deeper levels of sedation, as an example, it's a requirement to have end-tidal CO2 monitors. It's a requirement to have perhaps ECGs in some states and provinces. So making sure you have the right equipment in that environment, and of course access to emergency portable positive pressure oxygen, which is indicated in almost any medical emergency, is a must. The right team, again, if you're doing sedation, that has its own list of recommendations and requirements around it. But certainly you want to make sure that but the entire team meets current criteria. And again, that if there was a medical emergency, that they have clear defined roles and they know what those are. And then lastly, the right support. So while this graphic talks more about discharging the patient from care, but also it should involve some of the other pieces about, let's say, an automatic external defibrillator, if that's going to be indicated. What you should be doing as far as managing the patient while you're waiting for the EMTs to arrive, or in the case of a non-life-threatening emergency, how long you should perhaps keep the patient around the office for before allowing them to be driven home by a responsible adult, or perhaps they need to be taken to an urgent care or emergency room for follow-up. So lots of different things we want to think about, and it always comes down to kind of the environment. So we're going to practice simple manual with flowcharts. Sometimes that's a good idea. In fact, apps on your phone these days can oftentimes replace some of these physical manuals that we've relied upon in the past. And then I would say that the idea of your cell phone being part of your emergency kit is really important. I had one office that told me, we had this medical emergency, and I had sat through your course, Mark, and I remembered that our cognitive ability is inversely proportional to the severity of the emergency, and at the time I thought that was funny, but that would never happen to me. And sure enough, I had a patient, a cardiac patient, stopped breathing, told my staff to call 911, and while I was supporting the patient, and the staff kept coming back and saying, something's wrong with our phones, doc. We can't get a call out to 911. I continued to support the patient. Luckily, we were just down the road from the fire department, and so somebody ran down and got the firemen to come and help. And after all the dust settled and the patient was fine, which was great, I looked at what was on my hip, and it was my cell phone. I mean, every single one of us carries a cell phone, but in the heat of battle, not me, not my staff, not anybody thought about picking up our cell phones if the landline for some reason was not working. So I do think that your cell phone may be considered part of your emergency kit. All right, so equipment, typically less is better. There are some sort of pre-made kits that do tend to have a lot of equipment in them, and that's fine if you are used to using that equipment, placing an LMA in the patient, being able to bag breathe through a BVM, all of those things. But, if you are less familiar with some of the equipment, McGill forceps and others, you could end up making a bad situation worse. So really, we want to make sure that we manage the patient appropriately. We should have already called 911, and then hopefully just supporting the patient is all we need to do until the experts truly arrive. So the fundamentals really are as simple as I stated. Calling 911 is really the most important thing that you could do. And then be prepared to provide CPR or cardiopulmonary resuscitation. And if indicated, hopefully you have an automatic external defibrillator or AED if that's going to be indicated for the patient in front of you. Now, a quick word about AEDs. There are, in fact, public access defibrillation laws. Not a lot of people are aware of these laws. It's been recommended by the American Heart Association for a lot of years, but not all states have in fact adopted these types of interventions. So the American Heart Association, like many regulatory groups, make guidelines, but the guidelines are not necessarily laws. It's usually, in the case of dentistry, the state board of dentistry or the college of dentistry that actually makes the rules. And so they may not necessarily adopt them and say that, yes, all dental offices should have AEDs. In fact, one of their most recent statistics found that there's about 2.4 million public AEDs in circulation, but we need about 30 million in this country. So certainly something you want to think about. I will say that if we have AEDs in libraries, elementary schools, airports, supermarkets, why would you not have an AED in a healthcare provider's office? So regardless of whether you work in a state or province where it's required, there is not consonance amongst all of these regulatory agents that it is required in a dental office. So some of you may not have one, but I think the bigger question is why. And if you truly needed that as definitive care to save a patient life and you didn't, I think that would be a difficult one to sort of talk your way out of. You certainly can get AEDs now from not just the reputable companies, but also third-party sellers like Costco.com, or even Craigslist and eBay will sell refurbished AEDs, so overstock from hospitals. Nothing wrong with them whatsoever, and they certainly are at a much lower price point today than any other time in our history. If you are wondering, where's the best place, perhaps best state to have a heart attack these days, Oregon, according to this most recent evaluation by the CDC, is ranked as the best and most promising with regards to the number of AEDs they have to match the need. Now, if you were to take sort of one mental snapshot, this is that slide that I just love, because it shows that over the course of just 20 years, how successful AEDs have been in helping to save patients' lives. So this graphic starts almost 30 years ago. And almost 30 years ago, we really didn't have a lot of good Samaritan laws. We didn't have a lot of public service announcements, and not really a high level of, let's just say, consciousness in the general population as to how to manage patients that have a heart attack. And so if patients did have a heart attack and were lucky enough to make it to the hospital and got defibrillated, about 2% survived. So really pretty low number. When you fast forward just 5 years with early CPR, so now the American Heart Association started to provide cardiopulmonary resuscitation classes. We had Good Samaritan laws come out, getting patients to a hospital, calling 911, and being able to defibrillate them quadrupled the save rate to 8%, which again is fantastic. We were able to do a little bit better as the manufacturers got on board and started to make the AEDs a little bit more mobile. And so with early CPR, with early intervention, early defibrillation, survival rate went up to 20%. And then finally, where we are today, if somebody was to have a heart attack and we call 911, intervene early with cardiopulmonary resuscitation, AEDs are, ubiquitous. We just saw they tend to be, in a lot of different areas, libraries, schools, supermarkets, etc. And then also providing advanced cardiac life support on the way to hospital. Save rate is now up to 75%. So amazing trip over history, but you can just see how important AEDs are now to our emergency kit. Now, this next one is a little bit of a humorous slide, but I will tell you it is evidence-based medicine. It's taken from the New England Journal of Medicine. You can see the citation there if you want to fact check me. And the question here is, how critical is response time to survival? So what these authors did was they picked some of the most populous cities in the United States, and they checked to see, what was the average response time to patients receiving an automatic external defibrillator if indicated in some of our largest cities here in the U.S. And you would imagine that our most populous city, New York City, would probably be the best place to have a heart attack, but actually it fared as one of the poorest. You can see actually below the USA average. Who won the day on this report was actually airports. They have AEDs about every 100 feet, and so if somebody was to have a cardiac event and it was recognized, using an AED was sort of one of the best response times. Now, I have in fact blacked out the winner in this, and if you're trying to guess which city may be the safest to have a heart attack, believe it or not, it is actually the casino floor in Las Vegas. So casinos in Las Vegas have AEDs every 50 yards. If you're sitting there playing the one-armed bandit and you happen to have a heart attack and you go down, somebody will grab the AED, shock you, and ka-ching, prop you back up so you can just keep playing. There's a reason that Las Vegas has a high density of older people, because it's actually one of the safest places to have a heart attack in the United States. All right, medications. So we've made it through all of our preparation, our prevention techniques. We've emphasized the need to be surrounded by a competent team that has been practicing and knows their role. But let's talk a little bit about the medications. Now, your medical kit may be different from the medical kits that I'm about to show you. But again, there certainly is consonance amongst all the experts that the minimal dental emergency kit has 7 drugs, and in many cases, the 8th drug, Narcan or naloxone, should probably be added. This isn't new news. In fact, this is the publication from the American Dental Association. So your journal, the Journal of the American Dental Association, back in 2010, Mort Rosenberg and other experts took a look at all of the data to date, and they came up with the list that in the minimal dental emergency kit, there really needs to be at least 7 drugs. So for that true type 1 IgE-mediated anaphylactoid reaction, where, as I said, you don't have time to call 911. You really need to get life-saving epinephrine into that patient as quickly as possible. Epinephrine is the first one. For the less acute mild allergic reactions, or more of that histaminic reaction, an antihistamine such as diphenhydramine, also known as Benadryl, as a deltoid injection is what you need to have. If somebody does get the pains of angina, also known as ischemic heart disease, so the stress of dentistry, brings on the pains of angina, you need to have the reversal agent, which of course would be nitroglycerin, either as the tablets or the sublingual spray. For our patients with a history of asthma, oftentimes the stress of dentistry can bring on an asthmatic attack. And so if we have updated our patient's medical and pharmacological history, as we do before every dental appointment, and that patient has not brought their rescue inhaler with them, then a best practice is to make sure that your rescue inhaler is at chairside in case the stress of the dental appointment brings on that asthmatic attack and they need that bronchodilator, something like albuterol or salbutamol. For those patients, and we talked a lot about this already since it is a large and growing population, the type 2 diabetes epidemic, which is closely associated with the obesity epidemic in this country, being able to recognize hypoglycemia and how to manage it is going to be paramount. So we need to have some type of glucose. For those patients that truly have a myocardial infarction or heart attack, we're definitely calling 911. We need to get help as quickly as possible. If you don't remember the pathophysiology of a myocardial infarction, that all-important organ we have, the heart, has its own microcirculation. And if there is a blockage in that microcirculation, the downstream effect is a lack of oxygen, nutrients, and blood to that part of the heart, which means that if you don't resolve that and get rid of that blockage, that part of the heart will die, and we cannot resuscitate dead tissue. So in medicine, we say time is muscle. We want to call 911. We want to get our patients to chew an aspirin. Aspirin begins the process of fibrinolysis, which is going to start to break down that clot, hopefully reestablish blood flow, and we need to get that patient to the emergency room as quickly as possible to save their lives. And then finally, for syncope, aromatic ammonia, respiratory stimulant, used to be past tense, available in sort of this glass ampule that was surrounded by sort of a cotton mesh that you would snap under the patient's nose. That's been replaced of late with ammonia towelettes. Similar dosage form, just a slightly different and perhaps easier to utilize formulation. Now there is one thing I think that's probably missing from this table. So if you would permit me, I would also add portable positive pressure oxygen. So oxygen is indicated in almost every medical emergency, and I want to emphasize the idea of portable because not all medical emergencies occur in your operatory. If a patient has a medical emergency in the front part of your office, you want the ability to get portable positive pressure oxygen to them as quickly as you can. So those are the drugs. Lots of different formulations. If anything, I would draw your attention to that light blue box, because while we have always had epinephrine in auto injectors, while we have always had epinephrine as either ampules, that little glass ampule, or a vial to draw up and inject into the patient. And don't forget, epinephrine is always injected into the largest muscle group in the body. That's the vastus lateralis, or the thigh muscle. But there's a brand new product on the market here in the United States called Neffy, and that's a brand new intranasal formulation of epinephrine. And of course, there were 4 pivotal clinical trials that were approved by the FDA in bringing Neffy to market. And so we may start to see Neffy replace some of the injectable formulations of epinephrine because needle phobia continues to be an issue. We have seen some healthcare practitioners in the heat of battle suffer the pains of self-injection with some of these formulations, and so the new intranasal Neffy product would resolve some of those negative sequelae. As far as what your kit looks like, it could be something as simple as this. This is basically a tackle box. And within that tackle box, as long as you know what's in there and your drugs are kept up to date, it's very easy to access. There are some pre-made kits. I'm showing you one here. This is a little bit dated, as you'll see, because I had a friend who bought a dental office, and he told me, I sent you a picture, Mark. I bought this dental office, and they had a pre-made emergency kit. I've never seen it before. Looks kind of cool. Everything is sort of self-contained, and this is what it looks like. Of course, when he turned it over and highlighted, you could see that this emergency kit actually expired in 1979, which may predate many people on this call. So you definitely do want to make sure that you have an emergency kit, that it's complete, and of course that it's in date, and the drugs are also in date. Similarly, this very nice looking emergency kit looks to be very complete when you open it. It certainly has a lot of medications, but there's a couple teaching points here. First of all, in your emergency kit, you don't want it to just be the drugs. You want all the excipients. So if you needed needles, syringes, 2x2s, alcohol swabs, you really want one-stop shopping in an emergency situation. This particular kit is also unusual because if you took a closer look at some of these drugs, they actually should all be clear, colorless liquids, and in fact they're so old they predate the FDA requirement for listing expiries, and you can see actually that in the case of the phenylephrine and others, the intended clear colorless liquid has in fact taken on the color of the stopper. So probably not an emergency kit or drug that I would want to administer to a patient in an emergency situation. So what does yours look like? Well, as I said, you can certainly put together your own kit, or there are a number of pre-made kits out there. Now, the cautionary note that I always make with the pre-made kits is sometimes there are more excipients in there than you need. And if you pay a lot for your kit, and have done for many years, and finally you have a medical emergency, I know that's not how we usually word that, you are going to feel compelled that there's a drug in here that I have that I need to administer to the patient. And if there are more drugs in there than you would typically require, so beyond the 7 drugs plus naloxone that we would recommend, then it's quite possible you could give the wrong drug to the wrong patient and really make a bad situation worse. So what do we need to do? We need to understand our basic 7 emergency medications. I've gone through those with you now. And as I mentioned, naloxone, also known as Narcan, is considered to be maybe the 8th product. And primarily because on the backdrop of the opioid epidemic, and on the backdrop of having a patient population greater than 50% with some fear about going to the dentist, it's possible that our patients may take something licit or illicit before they come to the dental office. And if they happen to, get into a deeper level of sedation than you intend, and you're waiting for the EMTs to come, you may have to administer naloxone to reverse whatever licit or illicit opioid or narcotic they may have taken. One last piece on this slide, just for completeness, that if you do in fact provide sedation dentistry with any of the benzodiazepine products, so that would be your Valium-like drugs, diazepam, lorazepam, alprazolam, triazolam, midazolam, any of those ZAM drugs. Again, if you provide those medications to get your patients to relax, if they happen to get into a deeper level of sedation than you intend, you need to be able to provide that reversal agent, that very specific reversal agent known as flumazenil. So that would be included in those dental offices where oral sedation is being provided to patients. So what have we talked about in our time together? Well, we've really tried to piece together what's known as the chain of survival. And for us, recognition and activation of the emergency response system, that's the chain of survival that your team needs to always be prepared for. As I mentioned too, every 2 years, we need to make sure that our cardiopulmonary resuscitation or healthcare provider life support formats are kept up to date. And so the ability to provide immediate high quality CPR is also a requirement. It's a requirement of licensure. So you should all be well practiced and ready to go. The idea of rapid defibrillation, we spent quite a bit of time talking about the advent of the automatic external defibrillators and the need, as well as the progress that's being made with those to really have one available in a healthcare provider's office, such as a dental office. Basic and advanced emergency medical services. So that speaks about some of the monitors we talked about some of the drugs that we need to have in our emergency kit. And then post-arrest care, if required, hopefully that's happening outside of the dental office once the patient has been stabilized, thanks to the quick thinking and response of your team in the chain of survival. Now, I'm just going to finish off with one last right, right? We're trying to match up all of these rights. We're trying to set you, your patient, your team up for success. And so the right emergency kit was something that we talked about. And we definitely want to make sure that those medications are kept in date as well. So as a concierge service, many of these organizations will in fact track the expiry dates of your drugs. And if they do so, they will suggest replacing them as they come close to their best use dating. But at the end of the day, the onus is on you and your team to practice, to be prepared, and always, as I said, the right answer is to call 911. So I hope that was a lot of good information that's going to help you be better prepared moving forward. And I believe we have some time for questions. So let's get on that.
Thank you, Dr. Donaldson. That was very insightful presentation on medical emergencies in the dental office. Love it. And yes, we do have some questions actually starting to come in. So before I get to those, I would like to remind everyone to use the Q&A feature in the control panel on your screen if you have any questions. So first, let's see. What specific red flags in medical history would cause you to delay or modify treatment?
Great question. I think one of the big things that we look for as we update our patient's medical and pharmacological history prior to any dental appointment is basically what I call either control or uncontrolled. So patients that have a history of diabetes are, as an example, are they controlled or uncontrolled? If they have a history of angina, ischemic heart disease, are they controlled or uncontrolled? Most patients that are compliant with their medications, that have these chronic diseases, but haven't had any recent hospital admissions, are otherwise are well controlled. You wouldn't expect any type of medical emergency. In the case of somebody that has asthma, as an example, and I mentioned this in the presentation, if they didn't bring their rescue inhaler with them, then you want to make sure that your rescue inhaler from your medical kit is at chairside in case the stress of dentistry brings on an asthmatic attack. Now, in the case of the uncontrolled patient, that's really your opportunity at that point to deselect patients. I know we always feel like we have to treat all patients all the time, but if when you update a patient's medical or pharmacological history and you find that, they're just not as well controlled as you would like, depending on your level of comfort, depending on how well prepared you and your team are, maybe today you're going to change the planned operative, or maybe you're going to reappoint or even refer. A good couple of examples of this could be somebody that, is normally very healthy. They had a cancer diagnosis, and their most recent chemotherapy was this morning. That may not be the best patient to treat today. They've already got a lot going on. Similarly, if you've had a patient with, a recent heart attack, in let's just say the last couple weeks, and they're still probably not as stable or again as controlled. Those are some of the more challenging patients. And then lastly, because I did spend some time on it, given the high incidence of type 2 diabetes, specifically in this country, having a patient whose sugars are all over the place, or they were so nervous about dentistry that they went off their usual nutritional schedule, that's a lot less controlled than when we would like. And so being prepared for medical emergencies in the dental office is all about being prepared. And if you have an uncontrolled patient, it's really hard to be well prepared for a medical emergency. So maybe today's not their day to be in your chair. Great question.
Right. Yeah. So when a patient appears sedated versus hypoglycemic, what is your immediate decision algorithm without delaying care?
Yeah, great question. I know we touched upon this, but it is such an important topic just because, again, up to 50, that's 50% of the general population will have either diabetes or prediabetes by 2050. So we're going to see this quite a bit. When you match that against the other statistic that greater than 50% of the population also self-reports as being fearful of going to the dentist, we have a lot of our dental colleagues providing in-office sedation. In other words, providing the patient with some type of oral tablet, maybe a Valium-like drug, a benzodiazepine to get patients to relax. When you take a look at a very relaxed patient, somebody that's in minimal sedation or moderate sedation, they might appear drowsy, they may appear sleepy, they may be less coherent as they talk to you. And everything that I'm describing also is what patients look like when they are suffering a hypoglycemic event. And of course, your index of suspicion is going to be highest if this patient has a history of diabetes. And in almost all of these situations, it does tend to be that patient, last patient before lunch or last patient end of the day. So when you match all of those things up and a patient's just not responding to you well, or appropriately, maybe they seem to be sweating a little bit, maybe they do seem a little drowsy, and you have provided an oral sedative, the initial reaction is really to take a blood sugar, and we talked a lot about that the importance of having a blood glucose monitor in the dental office, given the high incidence of type 2 diabetes, makes a lot of sense. It's not a big cost, and you don't have to lance the patient's finger to squeeze out a drop of blood. Simply accessing blood in the sulcus, putting that drop on the test strip, and then pressing the button within 30 seconds, you will know whether you have great sedation or whether, in fact, the patient's blood sugar is low, and this could, in fact, be hypoglycemia, in which case we need to get some sugar into them as quickly as possible. So it's not necessarily, the time to call 911. It's to go through your differential as we just described, and try to understand, is the patient fine? They're just very relaxed, great sedation, or is this something where we do have to intervene because it could be hypoglycemia? Great question.
Yeah, definitely good to know the signs. At what point should a minor event like fainting escalate? Well, this kind of is a similar answer, I'm sure, but at what point should a minor event like fainting escalate to activating EMS?
Yeah, I think that this is one of those ones where we get almost a little desensitized to the fact that patients faint almost all the time, whether it's due to the sight of blood, whether it's due to being just nervous in the dental office, maybe they're extra warm because they ran very quickly, and now they're sitting in a warm operatory. For whatever reason, fainting certainly seems to be one of those pieces where patients revive very quickly, usually within 30 seconds. No medical intervention is required. And so we all feel kind of comfortable if the patient says, I'm okay to keep going with dentistry, and you've already got them prepped. But I do think that if this is the first time a patient has ever fainted, they don't have a history of fainting, that's probably a good time to get them checked out. Now, if you've already started to prepare the patient, maybe you've got some teeth open and you want to, finish the procedure, as long as the patient is fine with that, I think that that's appropriate. But I do think that in those cases, they should be going from your operatory to either the emergency room or the urgent care clinic to get checked out, because people don't just faint for no reason, especially if the first time it ever happens is in your office. We want to make sure there's not something more serious going on. If it does happen, the patient tells you, oh yeah, listen, every time I'm in a supine position in the dental office, or anytime I see blood or a needle, I faint. Okay, well that's going to be a little bit more commonplace, a little less worrisome. But similar to my comments earlier in the presentation, you're never wrong to call 911. And so if something happens that you're not prepared for, that the patient wasn't prepared for, it's always a good idea to get help and get it there quickly.
Right, definitely. Okay. So let's see. If I'm building my own kit, what are the 7 or 8 essential drugs, and in what forms or doses?
Sure.
What's the first?
So I think one of the easiest ways to think about this, so there's 7 drugs that make up the minimal dental emergency kit, and we covered them just at the end there. But the 7 drugs are 2 injectable medications. So you've got epinephrine for the life-saving type 1 IG-mediated anaphylactoid reaction. You've got an injectable antihistamine for the non-accelerated histaminic type allergic reaction. So those are your 2 injectables. And then the other 5 are going to be oral medications. So you're going to need some type of nitroglycerin, whether that's the tablets or the spray. You're going to need some form of sugar, glucose, for that hypoglycemic event that we just talked about. For our patients that have a history of asthma, you need to have a beta 2 agonist, so something like albuterol. Brand name is typically Ventolin. I think we're very familiar with that. If somebody really was to progress and have, a heart attack, where the right answer is call 911, call 911, call 911. While you're waiting for the EMTs to arrive, you want to be able to get aspirin into that patient as quickly as possible, since that starts the process of fibrinolysis and breaking down that clot. Now, the seventh drug in quotation marks is actually positive portable oxygen. because medical emergencies do not always happen in your operatory. So if somebody goes down in the front office, you need to be able to get portable positive pressure oxygen to them. And the easiest way to deliver that, of course, is with a BVM or bag valve and mask. So that's the critical seven. Now there is an eighth drug, simply based on the opioid epidemic that continues in this country now into our 26th year, which is hard to believe. And because we have so many patients that are nervous about dentistry, they may take some type of licit or illicit narcotic. And so then they come to your office and you give them a very safe oral medicine to get them to relax. And the combination of the narcotic or opioid that they took with your very safe sedative gets them into a deeper level of sedation than you intend, which of course is a medical emergency. So if you do oral sedation in your office, you definitely want to have Narcan, also known as naloxone, the reversal agent for opioids. And then, of course, the reversal agent for the benzodiazepines, which is known as flumazenil. Brand name used to be Anexate or Ramazicon. So don't get yourself locked into a serious drug collection. I know that there's a lot of other medicines out there, but there really are seven that are required in the minimal dental emergency kit. And then depending on your scope, adding naloxone and flumazenil kind of rounds that out to a total of nine.
Okay. And let's see. In a suspected, and another hypoglycemic event question, in a suspected hypoglycemic event, what is the preferred glucose source in a dental setting and why?
That's such an excellent and topical question. So the other ADA, the American Diabetes Association, as opposed to the one we're all so familiar with, the American Dental Association, the American Diabetes Association actually suggests that a non-diet carbonated beverage is really the drug of choice for a hypoglycemic event. So if you're from the Coke generation, a can of Coca-Cola, or if you're younger than me and you're from the Pepsi generation, you can certainly use a can of Pepsi, just not Diet Pepsi. So the carbonation is going to open both sphincters very, very rapidly. And then that allows the liquid sugar to get down to the small intestine where it's absorbed very, very quickly and elevates the patient's blood sugar. Obviously, there are many other forms of glucose, but in the heat of battle, it appears that perhaps the best, most efficient way is a non-diet carbonated beverage.
I love that. Is the Vita Alert kit big enough to fit a can of Coke in there too?
I'm pretty sure they could accommodate. Yeah.
I could just see, like, I could just imagine that situation. Like, anybody have a Coke?
Yeah,
That's
exactly right.
awesome. Okay, and so here's another question. When is naloxone realistically indicated in general dental practice?
Perfect. Yeah, so again, I was fortunate enough to publish an article with Dr. Stanley Malamed, who we've referred to a few times in the presentation, as well as Dr. Jason Goodchild. And the question that we proposed in our publication was, should naloxone be considered, part of the dental emergency kit? And so we answered this a little bit already, that on the backdrop of the opioid epidemic and on the backdrop of so many patients, people being nervous about going to the dental office, anytime you have an index of suspicion that patients may have taken something, again, licit or illicit, to reduce their dental fear, if they happen to get into a deeper level of sedation than you intend, you want to be able to have that emergency medication naloxone to reverse that. Now, again, I'm a pretty conservative person, so anytime something untoward happens to my patient that I can't predict or explain, I'm calling 911 right away. But while we're waiting for the EMTs to arrive, of course, you're going into your P, A, B, C, Ds, and one of those may be the delivery of naloxone to the patient. The great news for everybody is, you're not necessarily having to find a vein in the antecubital fossa or setting up a butterfly in the back of the hand to inject naloxone. Naloxone is available as an intranasal spray, so it's very, very easy to administer to the patient. And hopefully by the time you've done all the right things, the EMTs are coming through the door to kind of save the day.
All right, naloxone. Sorry about that pronunciation. Okay, and let's see. There's a lot. There's actually a lot of questions here. Okay, how frequently should mock emergency drills be conducted?
Yeah, great question. So, my suggestion is just have a pizza lunch, once a month, and maybe at that pizza lunch with your staff, you talk about one of the medical emergencies that may happen, whether that's syncope, whether that's a myocardial infarction, whether that's an asthmatic attack. You don't have to necessarily practice all at one time, but I think getting into a regular cadence of once a month certainly makes a lot of sense. If you don't want to do it that frequently, once a quarter, it would probably be fine. I would say at a minimum, though, twice a year. And what you're trying to do is make sure everybody knows their role. Now, there's sort of another piece to this question, which people might not be picking up on, and that is that we don't necessarily have the same staff throughout the year, right? You might lose staff, you might hire staff. And so you need to make sure that the new staff that's coming on, as part of perhaps their onboarding,
That's a good
that
point.
they are made aware of what their role should be during a medical emergency. Where do you keep your emergency kit? Who calls 911? Who stays with the patient? Are there any additional excipients that you may need? Needle, syringe, two by two, alcohol swabs, anything like that. So everybody does need to know their role, but yeah, I would say it's one of those things. I'm a belt and suspenders guy, so you can't be over prepared enough, and you can't practice enough.
The Vital Alert kit and protocol, being in onboarding. Take note.
Absolutely. Yeah, yeah,
That's huge.
exactly.
That's huge.
Underline those.
Yeah, that's a big one. Okay, and let's see. Okay, this is asking about red flags in medical history that would cause you to delay or modify. I feel like you touched on that a little bit, but are there
Yeah,
any in
this
particular
this
you
was
want to
again the
point out?
idea of controlled versus uncontrolled. So
Hmm.
whenever patients update their medical and pharmacological history with you, if they say that they take their medications routinely, they're in the case of diabetics always checking their blood sugars and it's always in the normal range, that's somebody that's well controlled, and I'm really not worried or expecting a medical emergency, especially if they've stuck to their regular nutritional routine and they had whatever meal they required on time prior to the dental appointment. They're not going to be at high risk for a hypoglycemic event. But that's going to be very different compared to somebody, let's say, has a history of high blood pressure or angina, and they're so nervous about the dental appointment, and they forgot to take their drugs this morning, and they don't remember doing that every single day. That becomes much more of an uncontrolled patient, and then really depending on your level of confidence in managing those types of patients, you can either proceed or maybe today is not the day to treat that patient.
Okay. And we'll go maybe a couple more, and then we're about out of time. What documentation is critical immediately after managing an office emergency? That's a good question.
Okay, so this is an excellent question, and I'm actually going to preface it by saying, read your regulations. Okay, not every board of dentistry, or for my colleagues in Canada, a college of dentistry, has the same requirements as far as self-reporting dental medical emergencies in the dental office. Obviously, the most important thing is to document something, all right? If it wasn't documented, it wasn't done. So put in, and especially if you can time orientate your recording, that certainly makes it much more user friendly or understandable if anybody was to ever take a look at your notes. But I would definitely sort of put in a, a dialogue round about sort of what happened, what you did, how the team responded, any drugs you used, doses, and I think it's really all about having an accurate history. But I think more importantly, and the reason I started off with read your regulations is some states and provinces actually require you to self-report to the dental board within 24 hours, especially if the patient goes from your office to the emergency room or if the EMTs show up on your doorstep. Now, I can't tell you, given the hundreds of people that we have on the line tonight, that your rules and regulations are exactly the same as everybody else's. So you definitely need to know your rules, and you definitely need to follow them. We don't ever want to put our license at risk.
Right. And definitely some form of reporting obviously makes sense. Let's see. How do you practically reduce fear or anxiety to lower an emergency risk without adding chair time?
Excellent. I love that question. So we've mentioned a couple times already that there's a high level of dental fear in the general population, greater than 50%. And so, if you're not already practicing sedation dentistry or what sometimes is referred to as sleep dentistry or, memory-free dentistry, lots of different sort of catchphrases for it. The idea of being able to just get patients to relax enough to accept dentistry is very important to their overall health care. So one of the ways we start, of course, is with our staff. We train our staff to offer TLC to all of the patients coming in. We have music in our office. Maybe you've got dark glasses you put on patients, blankets that you put on patients, anything to make them feel more comfortable. That's always the starting point. Now there are some interventions, and this is going well above and beyond, the hour that we're spending today, where you could be providing an oral sedative. And that certainly would not impact chair time if that patient was to take an oral sedative prior to being driven to your office. So, if you want to continue your education, if you want to learn more about this, the key terminology that we're looking at is minimal sedation. And there are certainly a lot of excellent minimal sedation courses you can take to learn more about how to relax patients and begin that process of relaxation prior to the patient getting to the dental office and therefore not extending chair time.
Great. Okay. All right. Well, that is all the time we have for questions. If we did not get to your questions, I apologize. We will answer it via email after the webinar. You will for sure get taken care of, but we just ran out of time. So, and just to let you guys know, in about an hour, we will send you a link to access this course module on the site. It's going to include that survey. Please take the survey, and then you will receive your CE certificate. And thank you, Dr. Mark Donaldson. I learned a lot. This is a great educational presentation. Thank you to our sponsor, which is Violet Kit. And thank you all for joining us.
Awesome. Have a great night, everybody. Thanks again.
We hope you enjoyed this presentation of Spark Study Club. You can receive CE credit for this lecture by visiting sparkstudyclub.com. Thanks again for listening, and we hope to see you again soon.